better sleep, sharper focus, a healthier life? It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Well, everybody, welcome to our podcast, No One Told Me, the Airway Health Connection. We are so excited to welcome the great Brita DeStefano, physical therapist extraordinaire, life-changing care. So thank you so much, Brita, for being here.
Thank you for having me. You know, I'm excited about this.
Oh my gosh. How long have we known each other now? It's been 5 years, 4 years, something like that.
At least, yeah, 4 or 5.
And I feel like we've both grown so much in the way we practice and what we do. And our practices have grown because of necessity to help other families. And it's just been really fun to kind of experience that growth together. Because, I mean, you know, and I know that we're both big on interdisciplinary care and like we can't act in isolation. And so we kind of need each other.
I don't think my practice would be where it is if we hadn't had that coffee 5 years ago or whatever that was. It was like during COVID. I don't know.
Yep.
But yeah, this collaboration is exactly what my practice has been built on. And it wouldn't be grown to where it is now without that.
Well, I mean, tell us about you. Tell us about your practice. There are so many people that follow you that, I mean, how many families have you touched with just your social media presence alone, of which you do most of it yourself, which I don't even know how.
I don't know how you do all the things you do. So, you know, we all have our thing. You know, the social media is a little bit of like just a love letter to my former self because I didn't have access to any of that information. You know, my children and the experiences I went through because my oldest is 11 and there was zero awareness, zero access to information, whether it was on social media, online, in person. I had none of this collaborative care and no access to what he really deserved to get in infancy that I now am able to provide for my patients. But it really informs not only my one-on-one practice, but just the information that I put out there too, because I don't want parents to go without access to that information like I did.
And what we tell so many families is that we don't want to see them forever. We want them to kind of graduate from care as quickly as we can get them the success they're looking for. And I think our personal experiences, your personal experiences play so much into how you manage families. And that's what I tell people about your team is you guys really meet them where they're at and you make care accessible because you provide stuff that can be done at home. And that's where the change is made, right? Like we can see them once a week for 25 minutes, but if we're not doing things consistently in the home, it's just not going to make as much of a difference.
That's the most rewarding part of being able to create my own practice and have it be exactly how I want it because I've been that parent. And so I know exactly what they need and exactly what they want. And then to create a team who's able to also provide that as an extension of, you know, what I created. It's really cool because we get to be these teachers that are really empowering the parents. We get to spend that whole hour helping them learn everything about their baby's body and how it works and what's their strengths, what are their weaknesses, how can you support them specifically? You're not just copying some exercise off the internet. Like this is your baby's body. This is how it works. And these are the things you can be doing at home. And it makes that carryover. I mean, what parent doesn't want to make their baby more comfortable? It impacts the entire family unit. Everybody's happier when your baby's not fussy and gassy and uncomfortable. And so we aim for that short duration of treatment. We want those babies feeling better and out of our office. I don't want to see you for a long time because I want you to enjoy that phase of your child's infancy. And so can we get them feeling good and get them on their way so that the parents can have that experience?
Yeah. And like you said, in that time, like parents do come out with more information than they walked in with. And sometimes can be overwhelming. Like you said, you have the 8-month-old who came in for head shape. We find there's a tongue tied to the tip that nobody's even brought up in an 8-month period. And the kid's having feeding difficulties that they don't even know of. So like, it seems like a lot of times you guys are a safety net for the things that sadly others haven't caught or brought attention to. I mean, I'd love to hear more about your background. So you're a physical therapist by trade. How did your emphasis on pediatrics come about? How do you navigate that as a PT?
Yes. So my background, if we rewind all the way, is that I was a pre-professional ballet dancer my entire childhood, young adult life. And so was really into how the body moves. It was just part of my everyday life. And I, through that, got a lot of injuries, as you do, and was in physical therapy. And I had an amazing mentor. The physical therapist who was treating me taught me, again, like the way we do for our families is in every session. I was 14, 15 years old, but she was bringing out her anatomy models and she was showing me what she was working on and teaching me about the SI joint and all these things as a young teenager that just planted that seed. So I've always been a nerd about the body and movement, whether it's related to dance or physical therapy. And so I thought going into my physical therapy program and getting my doctorate that I was going to be a PT for performing artists. And I couldn't be further from doing that now. And I can't exactly pinpoint when I made that shift, but it was part of the like doing all the rotations in physical therapy school where I got to experience pediatric settings where I realized that's where all that foundation happens. And they're also just more fun to work with.
Well, I think that's the crazy thing about it is like you're in the right space and you think you're with the right group. And then, like you said, you couldn't be further from it. But everything that you guys do is so foundational. And as like my own learning dives more into that, I realize the stuff we miss in infancy affects our motor patterns for the rest of our lives. Yeah. And I mean, you have such an opportunity to make positive change for families. So along those lines, like how do you check for motor milestones? What are your thoughts on some of the recent changes to guidelines? Like that's a big one.
Yeah. So I think what has shifted in my own career, so now throughout the 15 years that I've been working in pediatrics, is I started out more broad and I've niched down in specialty and in age. So we only treat infants. We see, I mean, my youngest patient has been 2-3 days old. And then as soon as they start walking, they're graduated out of our practice. So really being able to focus on that foundation and those younger ages. When I was in PT school, it was a lot of focus on I want to say like quantity, like meeting the milestone on time, doing X, Y, and Z, checking the boxes, looking at those objective measurements and saying, are they rolling? Yes, no. Are they crawling? Yes, no. That type of approach to pediatric care. And as somebody who is a nerd about the body and how it works and how it moves, I care so much more about how they're moving and the quality of that movement and how their body feels while they're doing it and how it's all connected because their feeding is going to impact how comfortable they are in tummy time. And then that's going to cause them to not learn to roll, all these things put together equal those milestones. So the milestone itself doesn't tell me as much as looking at, that baby more holistically. And so it's fun for me when somebody comes in because all they're concerned about is a milestone, which it's still important because it's telling us a lot about what's going on in their body, that then I get to be the detective and dive into, well, this is why they're not doing that milestone. Your baby's not lazy. That's BS. And no baby's lazy. They're all driven to move and they have things that can limit that, and getting to be able to put those puzzle pieces together and look at the actual quality of movement is what I enjoy so much about the way I practice now versus, what I was taught in school 15 years ago.
And well, I mean, that's one of the things that we talk about a lot with families is, we have modern day conveniences that we didn't have 20 years ago, 200 years ago. We have safe car seats. We have containers we can put our kids in. But how much is that stuff impacting your patient base? And I mean, we'll get to feeding in a minute because I think most people don't understand how much PT and feeding relate and why it's so integral. Like, that's a question we get all the time.
Yeah.
But how much do you feel that modern conveniences are impacting and limiting our ability to meet these milestones where they should be in terms of quality?
Yeah, it's really interesting because I feel like a lot of them are acting as compensations for an infant that's not comfortable doing what they should be doing, right? Like being on the floor or being on their tummy.
They
or
only like the car seat. They only
right.
like
Or they
this.
need to be upright in the
like that.
bouncer, or they can never sleep unless I, strap them into a stool, whatever it is. I think they are, when used intentionally and in moderation, obviously just fine. We've all put our kids in a bouncer and
heck yeah,
they're fine. However, I think for a lot of babies who might be struggling and those devices and those conveniences are being used as compensations, it helps those things fly under the radar longer because you're like, oh, well, it's fine. They just have to be upright all day. I'm like, well, have they been on the floor? No. Oh, okay.
Well, that'd be like an adult coming to you and saying, oh, it's fine. I can only sleep if I have 7.5 pillows under my neck and one under my left leg. Yeah. Like, we look at babies differently than we look at ourselves. And I tell people that all the time when it comes to like head turn preference or torticollis. I say, would you go to take a drink of your drink and turn your head sideways and then go take a big swig of it? And do you feel like that's comfortable? Because it's not comfortable for your child either.
Well, and I explain to people as well, the trickle down effect of everything that we do. It doesn't only affect one part of the body or one functional aspect of their movement, because everybody's slept funny and woken up with like the crick in your neck. And then you go to drive and you're like, oh, like all the compensations that you have to do in your body in order to just do your everyday activities when something is off with your alignment and your range of motion. And that happens to babies all the time.
Even from the birth process alone.
Not even from the birth process, even just from their position in the womb before they're even born. And so it's like, they don't deserve to have to do that type of compensation from day one for everything that they're needing to learn in that whole first year of life. So yeah, I think when we relate it back to things that we take pretty seriously in adults, but then just brush under the rug for infants, it's a little crazy.
Mm-hmm. And so I think a lot of people that are going to listen to this have an idea that there are milestones out there, but they're not really sure like what is classified as a milestone. So even down to like grasping our hand or suckling and rooting, like those are things that I think we take for granted and not knowing those are supposed to be present and eventually go away. What are the big ones that you would point out to parents or providers listening to this that they could classify as a red flag?
Oh man, there's so many things. So the first thing is that obviously newborns are born with those primitive reflexes, and those newborn reflexes, their feeding reflexes, and reflexes, because they are at that subconscious level. That is the framework that they are built with, so that it happens in that subconscious manner initially, so they can get started with the movements they need to feed, to move, to develop hand-eye coordination, all of those things. The reflexes are the blueprint. And then when the reflex activates over and over and over again, the baby begins to build a conscious motor pattern and learn the skill in a conscious way, so that as that reflex integrates or goes away, they now have that ingrained motor plan, that brain body connection to be able to continue that skill. So sucking is obviously a really easy one, that they have a suck reflex initially. If you put a boob, a finger, a pacifier, whatever it is in their mouth, they're going to suck on it reflexively, but it does go away. That reflex integrates. And then you look at a 3-4 month old, and now they're deciding, do I want to suck? Do I not want to suck? Did I establish that motor pattern, or were my reflexes a little bit inhibited because of a traumatic birth or prematurity or whatever it may be? And I didn't get the opportunity to build those reps and learn that movement pattern. And then I'm left with no reflex to help me. And it's really tricky. So obviously there's a lot of those reflexes that go into infant movement that can be, if they're not firing correctly, can be red flags. But I think a lot of the things that we look at when we're looking early on in babies is that postural symmetry, so that reflexes can integrate equally on both sides of the body, because we see so many of those, head turning preferences, the full C curve body. 99% of the time, if an infant comes into my office, I can tell you exactly what position they were in the womb. Their bodies just want to go right back into that position, and they run out of room at the end. Honestly, it's a small space and their bodies are developing rapidly, and they get those asymmetries. And it's obviously a spectrum. A lot of babies just come out and they can work it out themselves, and other ones stay stuck. And when we're limited on one side versus the other, we're going to integrate reflexes over here, but maybe not over here. We're going to get that little flat spot on our head. There's a lot of implications of just that good postural symmetry that can trickle down into their milestones. They might only roll one direction or crawl with that janky leg up. And those are the more overt signs, but we're seeing that sort of stuff from birth. And so we'd rather work on it then wait until they're crawling in that asymmetrical pattern at, 9-10 months old.
Yeah. I mean, and it helps with long-term movement, stability. It helps with brain health. There's so many different things that we can relate back to infancy.
Yeah. Their vision is all developed because of those reflexes. You're like ATNR, you're building that depth perception, your hand-eye coordination, all of it. Yeah.
And so that's where you and I overlap, right? Because I think people have a hard time understanding that babies with torticollis will often present with feeding problems, as an example. Well, and a lot of the babies with torticollis, we're also finding that there's structural midline restrictions or tethered oral tissues. Yeah. Can we weasel out of those with functional work? Maybe, to a point. Some of them, though, are so darn tight that we have to start considering like our release is indicated. And so that's where you guys, I think, are really exceptional in readiness. Like, you help prepare families very well. And you also collaborate with other disciplines like lactation in occupational therapy to get people the best outcomes. Because I think we run into this too. And this is why we have kind of like filters on our system for calls of, we can't just see people and schedule a tongue tie release. We need them to either be functionally prepared or have somebody kind of like signing off that this is an okay procedure. And is there really functional limitations? But we can't make progress in healing if they're still restricted in their body. So if you have that kid with the C curve, like, of course we're going to have tensor healing on one side because they can't move.
Yeah.
So, I mean, how do you guys address that? Like, it's a combination of manual therapy, movement planning, helping with the reflex integration, and improving on strength. Like, what's your kind of first line of defense, or is it all of the above?
Yep. All of the above, but it's pretty algorithmic at this point, because we understand, obviously what makes a successful outcome. If we send them to you, these are the babies that do really well and that are ready for it, and that we see optimal healing and they're functional as quickly as possible and they're seeing resolution of their symptoms. So we really have it, pretty down. And obviously every baby that comes in needs a little bit different approach, but the first line is always that manual therapy to see what is their body holding that we can release first. The problem with going straight to strengthening is that I can't strengthen in a range of motion that I don't have.
Totally. That makes sense.
So I think about, like, if we're going to go look in the mouth specifically, a baby who can't lateralize their tongue, I'm not going to do resistive strengthening exercises if they don't even have the capacity to move the tongue in that direction, if that makes sense. So we're working on that soft tissue work and the manual therapy first, so that then we can build the strength and the coordination on top of a better foundation where they actually have access to the movement that we're asking their body to do. And then, we do as much as we can. And then a tongue-tied baby is obviously going to have some degree of tension related to the frenulum that we're sending them to you to help with the final piece of that. And then it's that brain body connection. So that we call it neuromuscular reeducation, reteaching the brain body connection so that they can learn new ways to move. In infants, there's a really specific way that we need to do that because they don't follow directions. And so there's really specific ways that we can elicit new movements through different inputs that we're giving to the baby and that then we can teach to the parents so that they know what to do with their new tongue that you give them. Otherwise, they just have a big floppy tongue and not really an inkling of what we're expecting them to do with it. So that's the goal, really, is that we want them to get that nice release. We want them to have access to better range of motion in their mouth, because that's going to impact everything down the line as well, the way that ours is going to impact, the other direction. But they need to know how to use it. So we want them to be able to be functional with their new tongue.
Well, and I think this is what's surprising to people is babies are practicing swallowing really coordinated as in a pattern at 32 weeks and practicing swallowing before that as well. And if there is a midline restriction, it's present from the early weeks of life, like within the first 20 weeks is when that apoptosis or division is happening. So it's not like they just come out and it's like, oh, boom, there's a tongue tie. It's like the tongue tie was there while they were learning. And they've been learning for a long time as they're growing in that confined environment. So I like what you said about kind of making sure that you don't want to build strength on a restricted range of motion because it's not going to benefit anybody. It's like trying to do a bicep curl with half your arm. And if you're able to get that baseline and get them into a more functional position, work on strength building, work on that pattern, get them to a release provider who understands the importance of that, we're able to have those cases that are more on like that, I don't want to say instantaneous improvement, but we're more hopeful that the progress will be made so quickly. And we get that feedback from families all the time. Like we go to see them. We had a PT session, we had a manual therapy session, and immediately like feeding better, more relaxed, digestive. But then 3 days later, it was back. And it's like, okay, well, they have done everything they can to exhaust resources of not doing the release. But if that pattern is still coming back, we know that they're kind of harboring too much tension in their mouth. And that's kind of trickling down the whole system. So there's so much value in kind of that collaborative approach. And I think families just feel more supported and there's less fear going into something that's deemed very scary.
And I think that's part of what's so helpful is we get to dig a little bit deeper because I do these assessments, obviously, and I'm oftentimes the first person saying, oh, have you looked at this frenulum before? Has anybody seen this? And my first thing that I say to them is, I'm not going to blame their frenulum for what you came in here for or the symptoms that you're seeing until we weed through all this other stuff and make sure that it's coming from that and that they are actually using their body in an optimal way with the anatomy that they have right now. And then we will have a much better idea of what that frenulum might be causing, or maybe isn't. Maybe that was just a big old red herring and that baby's mouth is very functional, but they've got, something else going on. So that process, I think, helps take a little bit of the panic off of it, because what I tell them is you will be able to see improvement through the physical therapy. You don't have to just wait and we won't see any improvement until you finally get to go get the release. The PT will start that process and we will be seeing that gradual improvement. And then your baby's body gets to tell us when it hits that wall, because we are watching for that trajectory of like, oh yeah, week 1, we're up here, week 2, we're up here. And then all of a sudden they come back week 3 and we're like, oh, that baby really stalled out. We hit a plateau in our progress. That's their body being able to tell us, here's where my limitation is. I could have done more before. And that's what we saw the improvement with manual therapy and our therapeutic exercise. And then that's the limitation of what they can achieve with their current anatomy. And it just helps us really be certain that the release is the best next step, because they have told us with their body. We just have to listen and watch for that.
Well, and that's how we feel a lot of consults too, because for those they find us on social media, they're referred by a friend or anything like that. They come in and I say, I'm going to send you somewhere to make progress. forward, because all I care about are symptoms getting better.
Yeah.
So if I never see you again, that's great news. Like, I don't actually want to see you again because I want you to be doing so much better that this is a non-issue. But in the chance that I do, and in a lot of these cases, it's pretty darn high because they came for a reason. I say, no matter what, you're going to be so much better prepared and you're going to have so much more improvement than if you just go somewhere else and they just do the release. Those are the ones that give everything that you and I stand for a really bad name, because those are the ones that don't have the outcomes that we're looking for. And we were talking before we got on about like the layers to the onion. There's so many layers to human beings, and there's structural issues, there's genetic issues, there's gut issues. So there's so many things that we could be doing. And if we're kind of not looking at the big picture, we're going to miss something. So you said holistically earlier, like the holistic view gives you a better idea of what to treat versus being like, oh, I think it's this one thing alone.
Yeah. And I think that is such a good point, because you hear it's, very divisive out there about varying opinions regarding tongue tie. And it makes me so sad when I hear the parents say, I went and got a release and nothing changed. Because it's the last thing we want. It's the last thing you want as a release provider. It's the last thing I want as somebody who's focused on those babies making functional improvements. And in the back of my mind, I just know I'm sure that baby would have benefited from it, but it wasn't the right time. It wasn't the right time for the baby, or it wasn't the right time for the family because they didn't have the capacity to focus on, wound healing or whatever it may be, or maybe, I don't know, the provider wasn't the right provider, but that narrative is out there, which then kind of is scary to other families who are looking for validation and looking for help and looking for resources to hear, oh, well, it didn't do anything for your baby. And, just in my gut, I know it's that was just not the right time for that baby.
And maybe they didn't know what they were looking for either. And I think that's the value in the education that you guys provide. I mean, we run into the same thing with adults too. Like, I had a 20-year-old today who I had to like pull my mask down and give a lecture to. I was like, number one, I'm twice your age. I'm basically your mother, but you need to listen up because you've told me you're doing exercises. You've pushed this procedure back. It's very clear that this is a not great situation for you to be in, having a tongue tie release. Like, you have to do these exercises because I don't want you coming to us in 3 months or going around to everyone and saying, this didn't work at all. Because if we don't put in the work, we can't expect the surgery to be successful. It's the same thing for like a hip replacement, right? You have to have the body ready to accept it and accept the change.
Yeah.
And kind of the longer it goes on, because adults are a whole different beast, where the longer those compensations are going on, the harder it is to unravel because it just keeps layering and layering and layering. So, I mean, I think that's the really fun thing. And I appreciate you guys really taking a stand and limiting your practice to that particular age group, because it does give families a lot of comfort knowing that this is what you do all day and this is who you spend time with. And you really are truly experts in the care. So you guys there's a number of you now, which is amazing. And you've been able to expand your footprint. So there's home visits, there's in-office visits. And then in your clinic, you guys are running a ton of courses to help support families. Can you tell me a little more about those?
Yeah, we were really excited to move into our bigger space. I know you know the excitement of that because you're in that process and have been through it, that it just expands the number of families that we can touch by diversifying the offerings, because not everybody needs an hour-long one-on-one session with us, or they don't know if they need it or not. And being able to have multiple touch points for families to meet them where they're at, I think is really helpful. So obviously we have our PT sessions, home visits, clinic visits. There's 3 of us providing them now, but then we have that free tongue tie support group. So that one is a great, like, zero barrier, like, entry to just figuring out what this whole world of that collaborative support network is all about. And then the baby play milestone classes have been just such a fun addition to what we're doing at our South Denver clinic, because we get to talk about that healthy movement ways that they can engage their baby's body, helping them learn about the way babies' bodies are supposed to move and how to make all of that feel good. Because at the end of the day, it's what we say our little motto and what we're passionate about is that babies deserve to feel good in their bodies. If they feel good, they're going to feed better. They're going to sleep better. They're going to meet their milestones. They're going to want to do tummy time. And all of those things are going to feel easier if we just learn how to help them feel good in their bodies. And so the classes are just another way that we can help disseminate that information for families, even if they're not, needing to see us for torticollis or whatever it may be.
And you empower families to really know what to look for too, because nobody knows a baby better than their parent. Yeah. It's just many times we accept things that are common and call them normal because we don't know anything different. And there are so many mixed messages out there because we took crawling out as a milestone, which is a huge thing. Yeah. And a huge disservice because we're gonna miss kids. And that's what I'm seeing a lot of in the kind of 4, 5, 6-year-olds that we are treating a lot of is that they were the missed ones. They were the COVID ones and they didn't have the support that they needed because it just wasn't there. And there was so much fear and trauma. And a lot of these kids have a lot of unraveling to do that if we'd only caught them earlier, we could have helped them sooner. And that's what's frustrating a lot for families is, a lot of the things that you and I are talking about are dismissed so frequently. And families come in and they're kind of pissed off. They're like, wait, they told me this wasn't a problem. They told me that didn't matter. They told me that was normal. And so they're kind of pissed because they're thousands of dollars deep. And they're traumatized. They've been to so many appointments, like the number of swallow studies and sedations and things like that I hear about. We were talking about that with gut health. Like sometimes there's so much more than just the structural. There's the functional kind of approach that needs to happen to determine is there something else going on before we just do swallow study after swallow study. Yeah. It's hard.
I mean, you're preaching to the choir because my personal experience with my own child who's been through so much that could have been prevented with access to better resources 11 years ago. And if that's just my life mission now to prevent that for other families, then I'm so happy that that's what we got out of that situation. And I mean, to the point, you guys released a baby for us this week that is 8 months old and tied to the tip. They came to me at 6 months old because of head flattening. And I did my whole thing. I said, has anybody looked in his mouth? I explained, did our whole spiel. And the mom just looked at me with tears in her eyes and goes, is that why I couldn't breastfeed? And my heart broke. I was just like,
I know where that baby was born.
Yeah.
Mm-hmm.
And I said,
hospital?
Are you kidding? You weren't able to breastfeed. This baby's you obviously have now made it 6 months and not a single person wanted to look at why that baby couldn't breastfeed. Mm-hmm. And it's just, when you just see that, because it takes me back. It's like the exact same emotions that I went through when those light bulbs went off for me, figuring out oh, his tongue is still restricted. You mean his chronic ear infections and his tonsils and adenoid surgery and his sensory problem, all of those things, that's all because of this that we had from day one, and nobody put those puzzle pieces together. So it's really unfortunate, but it's getting so much better. I do have to say, with that hindsight of having the experience before, that the amount that practices like ours are growing and the amount of access that parents have now is getting so much better.
Yeah.
And I know you're doing a lot of work just behind the scenes in the dental community for that too,
yeah.
Which is
well, and I think that's the hardest part is it's a trickle down, right? And it's all based on personal experiences. That's when the light bulb goes off because it doesn't affect you until it does. And so many of the babies that I'm seeing that are caught and sent somewhere for support are coming from the nurses because, no offense to the pediatricians, but they're not looking well. And it's the nurses that are the ones that are listening to the patients. And they're the ones that are saying, I see something, you should talk to somebody about that. They're not diagnosing, they're not overstepping. They're pointing out something that very commonly is obvious. like you said, to the tip. I mean,
Yeah.
if we don't have a range of motion, like how are we expected to utilize our tongue? Like it's just not possible. So I get the idea of like, let's see if it impacts speech. We don't want to be too aggressive. But at that point, we've missed all of the milestones that you're talking about in the under 12 months. Like we don't have 9 months old out there with full sentences. At that point, we're way too late and we've missed safe swallowing for solids too.
Yeah.
I don't know. It's hard to see, but you're right. It is getting so much better. And I really applaud the people that have kind of like taken their personal experiences and made it not necessarily a mission, but at least they're open about talking about it. Because families are like that too, right? Like how many people are referred to you by word of mouth from their neighbor, from their friend. And it's like moms are talking, families are talking more than ever.
Yeah. And I think the providers that get to spend a little bit more time with the families are the ones that start to hear the red flags in those conversations, because we get the lactation consultants, the postpartum doulas, the midwives. Those are the ones that are starting to hear the patterns and referring more consistently, because unfortunately the pediatricians don't get as much time. So it's, not their expertise. It's not their specialty. And so, we really need those providers who are spending a little bit more time and can start hearing those stories to be the ones that are kind of on the front line with referrals, and they're doing it. Like that's what we're getting, is a lot of those providers in that postpartum space are understanding that it's not normal.
Yeah. And that kind of just goes back to like the big medical conversation of like insurance-based care it's challenging to allow families the opportunity for improvement, because there's not enough time in a 15-minute visit. There's not enough time in a, when I think about going to my pediatrician, number one, they're running 1 hour late, which in my office, at my dental practice, I would get 17 one-star reviews. Like it's amazing that the different standards that we're all held to, right? Like, oh, he's a doctor, it's okay that he's late. It's like, well, I mean, I just, this person, their face was swollen and we had to fix it for them.
Yeah. Or I just spent an hour with this family with their newborn baby that is, like needing that extra time to process what their child needs and all of that. So,
I mean, insurance-based care, it's challenging to meet people where they need to be met. Yeah. And I think a lot of times because of our current medical model, we miss stuff because we don't have time to look. So, I mean, we help navigate insurance. We can't always accept insurance. I know you guys are the same way, but your care is almost devalued when you're like, sorry, my watch is going off. I've got 12 minutes with you and that's it. Like we all deserve better as humans. And I think that's kind of the way that we see care going as we go more towards prevention, but
I think that also circles back to the importance of that like interdisciplinary collaborative care, because that way you have so many more touch points, so many more people looking through different lenses. That's what we were talking about a little bit before we hopped on about that collaborative care, where we've brought some other providers into our space specifically just to make it lower barrier to families reaching out and getting more assistance when they're already committed to coming in and doing our sessions. And so like that integrative gut health that we're bringing in, the speech therapist, the myofunctional therapy, occupational therapy, having all of that under one roof so that one person doesn't have to do it all. That's what's so hard, is that we kind of expect the pediatricians in a 10-minute visit to do all of those things. Mm-hmm. And they shouldn't have to, but they should also be able to have some more leeway within that medical model. And it's unfortunate that that's the way that insurance-based care
and even be open to making a referral. Yeah. That's kind of my biggest qualm is like, we're all limited in time in a day. Every person is, but knowing that
your limitations,
if we can recognize where someone else could go for support, that's what we tell people we spend a lot of time doing, is quarterbacking care. Yeah. Because like, essentially, if I never see someone again, that means that they have made so much progress. Like, maybe they're somewhere else, but I would rather think that they've made progress and the care that is not needed from what I can provide, which is like structural change, orthodontics or tongue tie releases or soft palate tightening. I would rather them explore their avenues and find success non-surgically and with minimal intervention. Like the low-hanging fruit is what we're always striving for. That's like, I think kind of the biggest thing that I've learned as I've navigated this space. When I first started, I was like, oh, it's just a structure. You just release it and it fixes everything. And like quick to figure out, there's so many more layers, and every day there's something new. And it's such a fun thing to be putting the pieces of the puzzle together and watching and hearing things that are really positive. So,
well, and I love what is great about your practice when we send families to you, even if they do end up just coming for the consult and we decide that it's not the optimal timing for a release, or they don't need a release right now, that they get plugged in with a practice that can carry throughout that child's lifetime, because the expectations of function and function changes. They're going to be eating solids. They're going to be looking into the jaw growth and development and all of that. And so I always tell people, like, go have that consultation, get to know them, and then you can use them as a resource at each of those stages. Here's when they're going to want you to come check back in. So if we don't do this release now, what are the things are we looking for in the future, so that we can make sure and maximize their function at every stage, not just in this infancy, because I graduate them out, but they're going to have things that come up down the road.
Things happen, right? And like kids fall down, a tooth breaks, they have trauma. Like there's so many different things that can impact our full body. So without a good baseline, it's hard to know where someone starts. Yeah. And I think that's the fun thing about assessing babies, is like I can almost predict what their growth pattern is going to be based on the functional pattern. And if we don't improve on that function, we are going to run into these structural issues with the skeleton. Yeah. And I mean, the number of times I see a child with a crossbite and I ask, oh, can I see a picture of them sleeping? And they're always, like butt up, head to one side, and they have a full skeletal crossbite now at age 4. And if we'd figured out that was affecting them, maybe we could have made some positive change. I don't want people to go and like change the way their kids sleeping, but kids are so prone to changes from pressure, like head shape. That's from pressure. And I mean, tell me a little bit about the physical therapy guidelines with torticollis. Like there's the newer one. Yeah. It says babies need to be assessed for torticollis within 1 month, correct? Like everybody should be referred to someone to have a true evaluation, not just pediatrician.
So I'm glad you brought that up, because now we have really great evidence that we can point to when people ask, why do we need to care about this? The new guidelines from the American Physical Therapy Association, so our practice organization, actually want babies to be screened for torticollis. So that's screening done by the providers, their pediatricians or whoever is in the hospital, in the first 2 to 3 days.
Wow. That's amazing.
So we're not even waiting a month. They need to be born, and then they need to be checked for torticollis, because it's congenital. It's not something that we need to wait and see if they get torticollis. If you have torticollis, you were born with torticollis, the congenital type. And so that early screening, when I work on a 3-day-old, my goodness, that duration of treatment is so short. Those parents get to get done with their therapy appointments. They get to go enjoy that baby, not be running back and forth to PT. And it's just such a better approach than waiting to see if it starts to affect other things. And then all of a sudden now they're have the head flattening and they're not rolling to the other side and X, Y, and Z. And we have to unpack a lot more layers. So I love that those new guidelines came out. I just don't know if there's enough awareness of them yet
well,
for that to trickle down in practice. We're doing lunch and learns at the pediatrician's offices. We are trying to get it out there, because that would save so much time, effort, money, stress, you name it, for these families if it was identified that early.
Well, and that's the thing with the tongue tie too, because like I think about it like this: the tongue needs to be contacting the palate appropriate, the upper jaw. It needs to be contacting and creating a certain pattern in the wave-like motion of the tongue and creating a vacuum seal. If it's not doing that, if it's disrupted for some reason, there's going to be an impact. Maybe it's spit up, maybe it's reflux symptoms, maybe it's hiccups, maybe it's back arching and belly discomfort. There's a whole range of symptoms that show up with this stuff. Well, the problem is so many families come to us with a head turn preference and head shape issues, and they're 3, 4 months old. Nobody's addressed that. And they finally are like, we found the tongue tie. And I'm like, well, we also have a skeleton that is now too narrow and a palate that is too high vaulted, so that when we do this tongue tie release, that tongue still has so much distance to travel. It's never going to create the greatest vacuum seal. So like, these first few months matter so much for setting these kids up for success. And when we miss something like that, it's really obvious. And we're just like, oh, put them in a helmet. Like, we're impacting oral function, we're impacting body alignment, we're impacting skeletal growth in the craniofacial complex and the whole body. So I don't know. It's so much more than just one thing. And I think we could talk about that forever.
It's fascinating just being able to see it in my own 2 kids, where one is obviously has very restricted range of motion, but that more significant, higher muscle tone, a better coordination, more postural awareness, like he has better motor control, versus my other child who has hypermobility and lower muscle tone, less motor control and postural awareness, and how that impacted their skeletal growth. Because the one who's more restricted, you would think, would obviously have more issues with, his narrow palate, his airway, whatever. Nope. It's that low tone, loosey goosey, one who doesn't have that same support for the muscles to be able to get them where we want them to be. That had, I mean, you've seen her airway, that had more of an impact. I mean, he's obviously had a lot more symptoms from the tie, but when you look at his jaw growth and development, it's very different than hers.
Yes. And it's probably like more symptoms because more tension
and more compensation.
Yeah. So, and I had that conversation today with Dr. Kack. I said, if I had a baby tomorrow, I'd choose a short, squat tongue to the tip, good collaborative care, less hypermobility, because if we can optimize that structure from the beginning, we can have better growth in somebody who's not kind of fighting that for a lifetime. Tell me a little bit about like hypermobility in infants and some of the things that you see and some of the things that concern you for the future.
As humans, we are seeking stability, right? Being unstable will trigger your nervous system. It will again, have that trickle down effect. And so everything that child needs to achieve in that first year of life is going to require some degree of stability in their body. And I like to think about the different phases of like infant milestones as going through phases of stability and mobility, because in order for them to get mobile in a position, they have to develop some stability in that position first. So they get really stable on their hands and knees, and then they move on their hands and knees, right? So we're going through these waves of, I'm really stable in tummy time. Oh, and now I'm rolling over, those waves of stability. And then that goes for affecting their oral motor skills as well. It's why do we wait until a baby is sitting up well before we give them solids? Because postural stability is so impactful for those higher level skills. And so in somebody who is hypermobile, they have less stability in their joints at baseline. It requires a lot more muscle activation to stabilize that joint. So we need a lot more of that postural strengthening to give them that stable foundation to work on those higher level skills. So it really impacts the way and the trajectory in which they gain those skills if we are on that spectrum of hypermobility. And that's a big thing that we need to look at, especially in a child who's hypermobile and has a tie. Are they using that tie for stability? And if we take that away, what's going to happen? Mm-hmm. And so there's a lot that needs to be more nuanced in approach with a tongue tie release in an infant who's hypermobile versus, like my older kiddo that has that stability in place already. So if he had more range of motion, he has better access with stability to work with it. So,
well, and we see that a lot in adults as well, and it trickles down into kids. Like the the hypermobility, it plays into airway collapsibility. So we need to find that stability so that we can also support the airway health, the airway musculature, because it's not just a solid tube, it can collapse. And that's where this stuff becomes so layered. It's strength, it's mobility, it's support. There's so many levels to it beyond just like the little piece of fascia, because oftentimes it does involve musculature, many times not in an infant, which is fabulous. But they need that support and stability before they move forward with procedures, or we're going to have a scarier outcome.
Well, and how many babies do we get with laryngomalacia who the ENT says, well, just wait, they'll grow out of it.
We're out of it.
Okay. What we need is that strength and stability. So we shouldn't just sit back and say, well, hopefully let's see how long it takes for them to grow out of it. Can we be working on strengthening those muscles to support the airway, and strengthening their postural muscles to support better breathing, and working on their oral motor skills so they have a more coordinated suck, swallow, breathe pattern, that they can get better palatal contact, all of those things. In my mind, I'm like, oh, there's plenty we can be doing. But most of the time they get told, oh, you'll just grow out of it.
We're out of it. Well, and then what does that cause? Some reflux, which then aggravates tonsilline adenoids to a point. The system's working harder, but then they grow out of tonsilline adenoids too. And like, that's always my argument, is we don't necessarily grow out of it, we grow more into it. So how can we help optimize a human as they're growing by working on their functional patterns? And I mean, I think that's, again, just one of the most fun thing is figuring out the puzzle and what direction does this person need to go individually. If you had a message for parents, new parents, parents of a 9-month-old, like, what would you be telling them right now?
That the quality of your baby's movement and how their body works matters just as much as them objectively checking those boxes for their milestones, that you're not crazy, that they deserve to feel good in their bodies. And when they do, all of those things are going to feel so much easier. And all of those things are going to fall into a place in a much easier way than when we're fighting against these underlying issues that are being glossed over in a lot of settings. And so, follow those gut instincts, listen to your baby, you know them the best, but they deserve to feel good.
That's fantastic. Well, and I would definitely plug your Instagram account. It's Progress Through Play. I think one thing you do, again, really well, just to circle back, is make things accessible for families. And even back to the container conversation, you talk about high chairs, about teethers, about things that are positive versus negative, or at least neutral for development, so that we're not putting kids in a situation where they're going backwards because they learn the wrong thing. So you have a ton of information on there. You guys are a wealth of knowledge. I so love working with you. Is there anything else that you'd love to share about your office, your team?
Just, we love to do as much out in the community, meet people. So reach out to us. We love to collaborate. And again, just check out the website and the Instagram account, because we really try and put as much of this out there as possible to make it accessible, like you said, and provide those resources that parents can't find elsewhere.
Yeah, I've learned a lot over the years and over this hour. So, well, thank you so much, Brita. We will talk soon.
Of course.
And I'm sure I'm seeing some of your patients, and I sent you like 3 today. So providers that are listening to this, whether you're a dentist, find somebody like Progress Through Play in your area. Maybe they'll keep growing somewhere else. Who knows?
Who knows where we'll go next?
If you are a pediatric PT, like, start screening for these things if you're not already, because it really does matter from a growth perspective. So thank you so much for your time.
Yay. Thank you for having me. It's so much fun.
Of course.
Thank you for joining us on the No One Told Me, the Airway Health Connection, the Untethered Way.
We hope you're leaving with new insights and feeling empowered to take charge of your airway health.
If you enjoyed this episode, be sure to subscribe and share it with anyone and everyone who needs to hear it.
To learn more or get in touch, visit us online at untetheredairwayhealthcenter.com.
Remember that when you breathe better, you live better.